Good morning. This is Dr. Dennis Mahali. This presentation is being offered courtesy of Freedom and Optimum Health Plans. It's directed, presented for physicians and their staffs to help them prepare for ICD-10. It really is for physicians, from one physician to another, and the idea is to give you information that'll make it easier and less stressful for you to get ready for ICD-10. One of the things you should know is that I am the CMS Physician Champion for ICD-10. That means I work with CMS in helping physicians get ready. It doesn't mean I know more than you. It probably means that I know where to get the information, and if I don't know where to get it, then I can reach out to CMS to make sure that you get the information you need to help you prepare. I'm turning to slide 2, Introduction to ICD-10-CM, and I want to make a point here. We're moving to ICD-10, October 1st, 2015, for the diagnoses. We will continue to use CPT procedural coding, but for diagnoses we're moving from ICD-9 to ICD-10. We're going to implement October 1st, 2015. I know a lot of you keep waiting for CMS to delay the implementation. That has not happened. October 1st is just around the corner. We all need to be ready. A couple of points on slide 2. Any claim, any service provided October 1st or later needs to use ICD-10 codes. Prior to October 1st, you need to use ICD-9. There's a lot of similarities between ICD-9 and ICD-10. They both use an index. They both use tabular section in the back where you find the codes. A lot of the conventions are the same. They have the same hierarchical structure. If you're familiar with ICD-9, ICD-10 should also be very familiar. Turning to slide 3, the physician perspective on ICD-10. Your job is not to become coders. You want to give your coders the information they need to be accurate and specific when they provide a diagnosis code. If you're one of the physicians that do your own coding and you know ICD-9, ICD-10 will be very easy. Trust me on this. You'll go to the section that has the major code and it'll be very easy for you to find the more specific or detailed code. ICD-10 is organized very much the way we think. A fracture is a good example. Is a fracture on the right side or the left side? Which bone? Is it proximal or distal? Is it spiral or transverse? The same thing with a myocardial infarction. What type is it? So it's organized the way we think. Why do you want to be accurate and specific? Well, not only does it make the information more accurate for your patient, but usually that specificity is going to come with better reimbursement and better reporting. My suggestion is you review your top 25 codes. Make sure you know how to code those in ICD-10 and the rest will be easy. Turning to slide 4, it's a comparison of ICD-9 and ICD-10. I'm not going to go over it. It's just a great slide that can show you some of the differences side by side. Turning to slide 5, we're looking at the ICD-10 format. I like this slide because it shows you how it's organized. And as you can see, the first 3 characters tell you the specific disease, and then the remaining characters are the ones that help you add the specificity, the etiology, the body part, the severity, etc. So if you get to the right 3 slides for characters for diabetes, The rest is easy to determine some of the more specific categories or diagnoses or subsets within diabetes. Our next slide is slide number 6. These are some of the new features found in ICD-10. I'm just going to speak to 2 of them. Laterality. So that's important when there's an injury. And I'm going to talk to character X. There are times when the code that the illness that you're coding does not have a 5th character for any one of a number of reasons, but it does have the 6th character. So it doesn't have the body part affected, but it has the severity of the illness. At those times you use an X, you put an X in the 5th character to allow you to continue coding and use the 6th and or 7th characters. You don't eliminate that character, otherwise you'll be coding improperly. Slide 7 also shows some of the new features found in ICD-10. The combination codes, this is fairly new, and the exclusion codes. There are 2 types of notes, ones that aren't coded here and ones that are not included. Not coded means they should never be used. Not included means it's not included in the code, but the patient could have both illnesses and both codes. My suggestion is simple. When you get to a point where you need to understand the exclusion codes, read it. Okay? Read it when you need it. Very simple. Read it when you need it. It'll make more sense when you're actually working with a particular illness, a particular disease, a specific patient. We're on slide 8 now, the elements of ICD-10 documentation. This is pretty good documentation whether you're in ICD-10 or doing anything. You want the disease or condition identified. You'd like to have as much detail provided. You'd like it specific to the encounter. Very, very important. When you put down a diagnosis code for a claim with a data service, you are saying that you addressed that illness during that encounter or visit. It's not there to say the patient has the disease. It actually is an attestation by you, the physician, that you treated that disease. You managed it, you evaluated it, you assessed it, and you treated it. Very, very important. A person can have a disease such as diabetes. You might list it on your problem list, but you would not list it in your claim if you did not actually work with a patient and address that disease during that specific encounter. If you turn to slide 9, it's again giving you some examples, good information. Asthma, we now want to know the type and severity. For fractures, were they traumatic or pathologic? For amputations, are they complete or partial? Is the amputation high, medium, or low? Just a little more specificity. But again, if you're in the right section of the ICD-10 book for amputations, it's pretty easy to review the choices and determine the proper code. What's difficult is if you don't write down, if you don't document in your EMR or your paper record the information, then your coder is left to either guess or be very, very general. We're now on slide number 10, and we're talking about myocardial infarctions. And here there is something different, but it's not very difficult. Obviously, you can be specific whether an infarct is subendocardial or transmural, but it's the time frame. In the past, an MI was considered acute if it was within the first 8 weeks. So for the first 8 weeks, you were treating an acute myocardial infarction, and after that it became an old MI. In ICD-10, that period has changed from 8 weeks to 4 weeks. So if you're more than 4 weeks, we're now discussing an old MI. Slide number 11 talks to, well, it's really just some good advice for documentation, whether it's ICD-9 or ICD-10, and this will help you keep out of trouble, and it will also give your coders, your staff, the information they need to choose the correct code and to be as specific as possible. So slide 11 says HCC documentation, MEAT, and that MEAT stands for monitoring, evaluating, assessing, and treating. Monitoring is usually it's the HPI, and you're figuring out how the disease is going. You're capturing information from the patient. Have there been exacerbations? How are they doing? Etc. You might be checking blood pressures and blood sugars, etc. Evaluating is often the review of systems and the physical exam and test results. Obviously, a patient who's wheezing is having a different experience than one who's breathing unlabored and quietly. Assessing is you're determining the status of the disease. A patient can have diabetes, but is it stable? Is it improving? Is it worsening? Is it controlled with meds? Is it volatile? Is it resolving? So I encourage you that when you are putting down the diagnosis or in the assessment section of your note or your EMR, don't just put down the disease, but give a couple of words to describe it. Asthma well controlled on meds. Diabetes with no complications or side effects or manifestations. And then, of course, treatment is the usual treatment, medications, therapies, referrals, return to clinic. Okay, so we're on slide 12, which is an example. We're going to use a few examples to help everybody. For those of you who are thinking about this, there's only 22 slides to this presentation. We're halfway through, and if you can stick with me for a few more minutes, I think you're going to get some very good information. In this slide, Ms. Geller presents to the office with arm pain, some swelling, and the X-ray confirms a fractured radius. That's not very good documentation for ICD-10. ICD-10 would like to know which arm is fractured, the laterality, left or right. Is the radius fractured at the upper end, proximal or distal, the shaft? Is it a green stick fracture, a spiral fracture, a transverse fracture? Is this the initial episode of care, subsequent? Are we seeing union or non-union? These are all things that a doctor would normally document. It's questions we would normally ask. And by putting it into the record, your coder can be more specific. So now we're on slide 13, and this shows the improved version for the example we just covered. Ms. Geller comes in for an initial evaluation after falling off her skateboard. She complains of left arm pain with swelling. The X-ray shows a spiral fracture of the left radial shaft. You'll notice that in ICD-10, when there's an accident, ICD-10 would like to know where the accident happened and how. Did someone fall off a bike? Did they fall off a skateboard? Were they riding down the street? So this additional information is important for you as the physician to document. Obviously, if you don't document it, your coder has no way of putting in the proper code. Not difficult to remember, where did it occur, and what was the patient doing. So in this case, you can see the two codes, but it's a displaced spiral fracture of the shaft of the radius, left arm, initial encounter for closed fracture, tells us that bone wasn't sticking out, injury due to skateboarding. So those codes that I mentioned are called activity codes. The category is Y93. Most of us would just put a tab back there, so whenever we have this type of injury, we can turn back to the activity codes and look them up fairly quickly. There are secondary codes for use with other external cause codes to identify the activity of the patient at the time of the injury. And you only use the activity code once. So in this situation, the primary code is actually the code for the fracture, S52.342A, and the secondary code, Y93.51, tells us what the patient was doing. Not very difficult. Again, this is something your coder knows. You just have to remember to put it in. What was the patient doing when they were injured? Slide 14, example 2, is another example of insufficient and then sufficient documentation. Chandler Bing comes into the office for follow-up of his atrial fibrillation. Okay, so we know it's follow-up, so it's not new, but that's all we know. Chandler Bing comes into the office for a recheck of paroxysmal atrial fibrillation. We have a little more information about the atrial fibrillation. We're on slide 15, and we have another example. Phoebe Buffet is back in the office for her CKD, chronic kidney disease. She will continue with her current meds and follow up in 3 months. All we can do is say this is chronic kidney disease unspecified. If we say that Phoebe Buffet presents today with stage 4 chronic kidney disease with a GFR equal to 30, continue meds, return to clinic in 4 months, we know that this is now N18-4 or severe chronic kidney disease. Slide 16 is a very easy way for you to get an assessment of where you are in terms of your readiness for ICD-10. You should do some internal audits and look at your own notes. And I think it's best for you to look at your notes. Don't give it to the coder, because it will help you realize where you're doing well and where there are gaps. Is the disease fully described? Is the location evident? Is the condition staged and linked? Are sequelae known? Is the plan of care clearly evident? Have ambiguous statements been clarified or corrected? By you doing it, you'll internalize it. If someone else does it, then they're handing you a report. It may be somewhat abstract. It may not get the results that you want. Slide 17 is a review of your EMR templates. And first and foremost, you want to make sure that your templates have the types of things that might be missing, that the types of things that ICD-10 is looking for. So if there's no laterality on your template, right away you know to fix it. If there's no specificity into locations or diseases, you know that has to be corrected. Clearly you want the chief complaint evident. Please remember to make sure that the history of present illness is authored by the physician or the clinician only. You want to make sure there's a place for external causes. There's a lot in ICD-10 when someone is injured. There's a lot of information about the external cause. Not just were they in a motor vehicle, but were they in a car, a golf cart, or a scooter, as an example. You want the age of the MI documented, so you know if it's old. The route of medication should be documented. Medication should be reviewed and updated, and we should mark when they're ended. We're no longer giving them. Chronic conditions should be either active, resolved, or non-existent. I know we like to keep a list of past medical history and what illnesses a patient has had. We should make sure that the problem list only contains those illnesses that are acute or active. They can be chronic, but they're active. So update the problem list and remove things that have been resolved. We're now on slide 18. Probably a really good idea for all of us to review our EMR, our health record templates. We want to make sure that they're consistent with the new options in ICD-10 And I think, as I already mentioned, if your template didn't distinguish between right and left injuries, that wouldn't be acceptable. In this case, I'd like to take a few moments and talk about dominant and non-dominant indicators. In many instances, you may not know whether the patient is dominant or non-dominant on the side of the injury. So there's a very simple convention. If the patient is ambidextrous, the default code should be dominant, if you don't know. If the patient injures the left side, the default code is non-dominant. Obviously, if you know that the patient is left-handed and left side dominant, that would not be the case. This is the situation where you do not know if the patient is dominant or non-dominant on the side of the injury. If the patient is right-sided, in terms of the injury, the default is dominant. Very simple. All we're doing is we're assuming when we don't know that most people are right side dominant and left side non-dominant. If you know, obviously you use the information that you know. The rest of this slide is pretty straightforward. We all know about gestation. We're going to start to add it. We know about the Glasgow scale. We're going to use it. If we know the organism that might be causing an infection or other illness, we're going to identify it. And when we have respiratory failure, we will note whether or not the patient is hypoxic or not. We're on slide 19, by the way, in case you didn't capture that. The physician readiness checklist helps you determine if you're ready for ICD-10. Have your doctors attended ICD-10 education? Remember, we're not asking them to become coders, but at least some education is important. Have your nurse practitioners and PAs attended? Have your nurses and administrative staff attended ICD-10? Have the doctors and staff coded any visits in ICD-10? Has the practice audited any ICD-10 coding? Has a third party audited any ICD-10 coding by the practice? Obviously, if you've done none of these, expecting that October 1st you're suddenly going to code properly might be a little ambitious and overly enthusiastic. These are not difficult things. It's probably a good idea to have one person in the office certified in ICD-10, but the rest of the people can take courses and make sure that they're doing things the right way and providing the documentation. Slide 20 talks about the EMR assessment. Are you using the most current version certified for ICD-10? This is very important. Please listen to this. You may have an EMR and people tell you it's certified for ICD-10. Often that's the latest version. That might be version 10 as an example. If you're on version 8, version 8 may not be certified. So you need to speak with your vendor and upgrade your version. Has the staff used the EMR to code visits in ICD-10? Have they audited the ICD-10 to make sure it's working properly? Has a third party audited the EMR ICD-10 coding to make sure that it's producing the right code? Testing. Has the practice used the CMS free ICD-10 testing? I think by the time you hear this, that free ICD-10 testing will be over, but you can check with us. Perhaps CMS will open it up again. They've been offering it now for more than a year. Obviously, if you haven't done the free testing, reach out to us. Did you pass? Did you create a plan to correct any issues identified? We're on slide 21. Again, the ICD-10 readiness plan. Does the practice have an ICD-10 plan? Does the plan address issues identified in testing? Has it been updated for 2015? Will the practice be ready by October 1st, 2015? There's a very nice ICD-10 readiness website for CMS. It's free. You can visit it. It's here. And as I mentioned, we have an ICD-10 one-pager that we hand out. Our network team should have it. I know our MRA team has it, and that'll make it easy for you. You can just ask your network representative, and you can go right down the list and in probably 15 minutes determine if you're ready. And then the very last slide, slide 22, is a reference slide with some links to places that can provide additional information. I think the best link is if you go to CMS, you can look up the Road to 10, and it's got a series of nice, simple links and handouts, information to help you get ready. In fact, you can probably just key in Road to 10 in your Google or your other internet browser, and it should bring you right there. This concludes the presentation. If you have questions, please let our field team know. If you feel that you need some additional support, please let your representatives know. And if you have something specific and you want to put it into an email, send it to your network rep, and I'm sure they'll get it to me, and I'll try to get you the right answer. In most cases, this is not difficult. It'll be difficult if you don't start. We're now just a little more than 100 days away. That's when I'm giving this. By the time you hear it, it's probably going to be within 90 days. I wish you good luck with this, and again, as a physician, I can tell you that ICD-10 is organized the way we think. There's not a lot of difficulty in it. Don't be dissuaded by the number of codes. Most of us only use about 25 codes. Now, within those 25, you may have 3 or 4 different options. So people may tell you, well, now you've got to use 100. But I can assure you, having done this, if you get to the right code, a fracture of the arm, or hypertension, or diabetes, if you get to the right section, you can look down the page, and as a physician, you'll know right away which code fits the illness for which your patient presented and for which you're treating. Please don't forget the fact that you have to assess and treat the disease in order to list it in the diagnosis. Thank you. Good luck with ICD-10.